I'm gonna make it my life mission, my life mission to educate people on what we do as physical therapists because we have such a unique role in the healthcare system that no other profession has.
All right, and welcome back to the Price for Paradise. My name's Woody, aka Creston Woods, and with me today, a return guest. We're bringing back Austin Pitchford, PT for Spooner Physical Therapy, and he's back again to extract some of his knowledge. And so, thanks for coming back on the podcast,
Yeah,
brother.
thanks for having me. It's fun to be here.
Yeah, first time we got him on the video. So, I wanted to make sure he came in. We've been making lots of content lately about, making sure we can assess mobilities, and it's been really fascinating. So, I wanted to bring him back in here and start to talk about some of that. And he's a fan of golf. And so, I know, have you been playing lately?
I'm pretty good. I'm at a 2.3 handicap right now.
So, he's not bad, guys. He's not bad. But I've added a few golfer clients to my client list, and we've been dealing with some injuries, some range of motion problems, and one of the ones that they've been mentioning to me is either golfer's elbow or tennis elbow, which I was just talking to Austin a minute ago about, which I didn't know that there was two differences. So please, can we go in on about,
Yeah.
tendinitis?
Yeah. So golfer's elbow, you'll typically see along the inside. So that's called medial epicondylitis. Tennis elbow, you'll typically see along the lateral epicondyle. So lateral epicondylitis is the medical term for it. So typically those dysfunctions are not as much of a overuse issue at that site, but it's more of a dysfunction of strength or mobility at the wrist or the shoulder. Now that's not all the time. Sometimes people are just returning to an activity and doing way too much, and it's just a lot of stress along that medial epicondyle or the lateral epicondyle, and that's why it's important to always just get assessed and not just do general strengthening exercises. What we'll typically see, let's say with a baseball player that has a lot of overuse through their elbow, or a golfer or a tennis player, is that they're going to have poor shoulder stability. So their parascapular muscles, their shoulder blade muscles, are going to just be generally weak, especially compared to the other side. Or if this is their dominant side, it's really inherent that they strengthen those parascapular muscles more than those front muscles like your bicep, your pec, that type of stuff. What we'll also see is a lot of golfers specifically or tennis players lack wrist extension, and that can be a huge deficit for a lot of people. So if you can't access wrist extension in a lot of sports, then you're going to overuse up the chain. Same thing with the shoulder. We'll see lack of external rotation with some golfers, which can create excess use through the shoulder, or I'm sorry, through the elbow. So as far as golfers go, the reason why we call it golfer's elbow is we'll typically see, so if you're a right-handed golfer and you're going down, it's going to be on your right side at contact. That's typically when it's going to hurt. Not all the time, but it's right when you're taking that
So you could
pivot.
get tennis elbow from golfing, but
I've
it
seen
is
it.
just like more likely because of the way the swing path goes.
Right, and again, it's great to get assessed by a physical therapist and go through a full movement screen because this is not a one-size-fits-all type of dysfunction or pathology. But typically with golfer's elbow, we're going to see it on the inside, and it's going to be at contact that people are going to feel that pain. Now, I've also seen tennis elbow on the right side for a right-handed golfer because they're excessively using their hands, and
Oh,
that's
they're
a whole
flexing their wrist.
they're
Oh.
flipping. Those are usually people that hit like a duck hook and kind of flip it through.
They probably need to work on their golf swing as well as go to PT.
Right, and that's more of probably a lower extremity issue that's causing this, and that's
Yeah.
why it's important to get a full assessment of those things. But typically, you'll see that, and then with tennis elbow, I will see that a lot with obviously tennis players because of that excessive pronation when hitting a tennis ball. I also see it like middle aged. I've seen a lot of middle aged dads that are throwing with their kids, and it's just a lot of overuse, like throwing the football or throwing the baseball, and they're not used to doing that in the last
20 years
20
ago, yeah.
years. Yeah. And so that just a lot of overuse through that area. So going into some different treatments that we give for that. So what you'll typically see if someone has golfer's elbow is they're going to have poor supination or poor supination strength, and then vice versa with tennis elbow. So they're going to have some limitation going through pronation. They're going to have pain with pronation strength. So one of the easiest exercises that I give to almost everyone with golfer's elbow or tennis elbow is doing eccentrics. So if you have golfer's elbow, you're gonna have your arm at 90 degrees, and you're just slowly going open and then back to
And so
neutral.
you're holding like a sledgehammer, you're holding like something with weight or something that even just a PVC pipe if you have
Hmm.
to kind of regress it.
Yeah, just anything. I mean, I've given people up to 1 pounds to 5 pounds, just something fairly light. PVC pipe, a dowel rod, golf club, hammer, anything like that. So you're just gonna go palm up nice and slow. I always say 3 to 5 seconds on the slow eccentric phase, and then quick up. 3 to 5 seconds, quick up. Now, if that's too much for them, they can go through the eccentric phase, grab the hammer, PVC pipe, whatever it is, and then assist it back up and just slowly working just through that eccentric phase. So when we're trying to rehab tendonitis, especially when it's acute or if it's something that's just lingering in that area, you want to always do eccentrics. So eccentrics are where you're lengthening that muscle and you're getting more muscle activation doing eccentrics versus the concentric motion, which is usually what the painful motion is,
The
and
movement
that's to bring
portion,
it
yeah.
back through it. Vice versa for tennis elbow, you can go here, but you're going through pronation now. So down, back up, nice and slow down, back up, and then you can regress it
Do you
from
think that
there.
there would be like any potential benefit to training both of those, prior to actually having tennis elbow or golfer's
Absolutely.
elbow, making sure that those things have strength through those ranges?
Yeah, and that is something that I want to talk about later in the podcast. I think it's great for any athlete to have a full body assessment by a movement specialist like a physical therapist because so many people have strength deficits, mobility deficits that they don't even know about. And it's really great to catch onto that dysfunction before it leads to pain. It's a lot easier to treat something before it gets to that point of pain versus getting someone out of pain and then treating the deficit from there. So,
And every single person has imbalances. I mean, Austin's
absolutely.
assessed me like 10 times and told me that I'm all messed up all over the place. So
Right. Yeah, and I am too. We all have something going on, and at some point in our life, that deficit's going to catch up to us. But it's really good to get ahead of the curb by having someone assess those deficits before it catches up to you, and then it creates pain. And I always tell people that pain is something that doesn't just happen overnight. It's something that's unless you're in a car accident or something like that.
yeah, a big trauma. Yeah, that'll
Yeah,
that'll do
that's a little different.
it.
But typically, with overuse type of injuries, you're going to see that pain is something that has taken multiple years to lead up to. And so, if you can get ahead of the curve by having someone assess that and tell you what your deficits are, that's just going to make you a better athlete, human, whatever it is that you're trying to work towards.
And if you don't get assessed and you just rest, that thing's gonna keep coming back,
Correct.
guys. Like, so you're gonna go golfing, and then you're gonna wait 2 months, and you've like, oh, I don't feel any pain. Go golfing again, and then all of a sudden it's back, right?
Right. Yep. So going back, I'm sorry, what was your original question?
So yeah, and then let's break off of like elbow tendonitis, and let's like work our way up the body a little bit. And so I also have some thoracic mobility problems,
Mhm.
and so can you talk to me about how we can get people's spine more open up, and so that we can I guess so I can help them, increase their range so their
Yeah.
swing, they can add 20 yards to their drive.
Yeah, so thoracic rotate. So your thoracic spine is your mid back. So we have 12 different vertebrae in our thoracic spine. It starts around our traps here, and then it goes to where our lumbar spine is, and that's where we start to get a difference in curve. So just to do like a little spine review first. So our cervical spine has 7 vertebrae, and our cervical spine is in a lordotic position. So it's curved. Hard to
Yeah.
demonstrate, but it's curved where it's. I don't know what I'm trying to say.
Yeah.
It's a
That, like,
reverse curve from the thoracic spine. So the thoracic spine is more kyphotic. So that's the
okay.
opposite of lordotic. So once you get down to your lumbar spine, which has 5 vertebrae, you're going back into that lordotic position. So you have a lordotic spine, and then you have a kyphotic spine, and then a lordotic spine. So our thoracic spine, because of its orientation and how it's formed, can just get a lot tighter than our cervical spine and our lumbar spine. So naturally, our cervical spine is mobile, our lumbar spine is mobile, our thoracic spine is a little bit more restricted in general. And then you add in that we sit a lot as humans, we slouch, we're on our phone, then that thoracic spine is going to get even more and more kyphotic.
Does it just like because it takes the most, I guess, stress off of the whole body's posture?
Yeah, it just makes it feel better when you just kind
Yeah,
of sit like
slouch.
that.
Yeah.
Yeah. So, I mean, that's a whole other rabbit hole. But so, as far as thoracic spine, restriction goes, it's one of the biggest issues that I see with any of my patients. So, improving thoracic spine mobility can unlock so many different things. I could go on a list of that. So, overhead mobility, getting more rotation with the golf swing, which inherently is going to improve swing speed, which should improve ball flight. I mean, we're talking overhead pitching, swimming. I mean,
Name a sport that doesn't
literally
have like rotation to
anything. I
thoracic
mean, even
spine.
running, walking, we need thoracic mobility. I mean, I even see it in people with walking that they do not move
They're too
their
tight. They're just
thoracic
like trying to,
spine.
they're too stable here, and then everything looks so hard to fight through.
Yeah, so just so many people have thoracic spine restriction. It's one of the biggest deficits that we have as humans. So a nice easy test to just see, okay, what is my thoracic spine mobility? It's generically we want to have about 60 to 70 degrees of thoracic mobility side to side. If you're limited by about 5 to 10 degrees right versus left, that'd be something to work on. But you would go hands across your chest, and we did this together the other day. Hands across your chest, bring your knees together, which we don't have much space for here. And then you'll cross your feet. So that is just locking down your lumbar spine so that you're now isolating your thoracic spine. Now you're in a wheelie chair, so it's not crazy accurate.
Yeah.
But then from there, you're going to rotate as far as you can to the right, and then you're going to go as far as you can to the left. So Woody has quite limited right rotation, which I'm not surprised by because he played baseball. He's a right-handed, correct?
Yeah.
So a lot of baseball players, they just have a lot of right restriction down the road. It's just something that catches up. I'm the same way. And
I mean,
that's
we've
something I
done
have to work on.
100,000 throws or swings in one direction, and then you do like maybe 100 the other direction, and
Yeah.
so it's some muscles are going to build up differently than the others. But
Yeah, and some people, I mean, scoliosis, a lot of us have mild scoliosis too. So you're naturally going to maybe have some restriction. That's just how we were made. Um, so as far as thoracic mobility goes, so you had, I'd call it 40 to 45 degrees of right rotation versus your left side looked pretty good. You're about 65 degrees. So just some easy exercises to work on for that is just doing an open book or a book opener where you're on your side, having your knees stacked up, or at least having that top knee up over a foam roller or laying on your bottom leg and just doing rotations like that. Now, I always like to tell people it's not a shoulder exercise, it's a thoracic exercise. So you're trying to bring your sternum up towards the sky and not just bring your arm into shoulder extension. So that's one of the most commonly prescribed exercises that myself and probably most physical therapists give to patients that just helps open things up. Now, I also spend a lot of time working with people on rib mobility. Rib mobility is huge when it comes to the thoracic spine because your ribs all attach to your thoracic spine. So if you're
Yeah.
just holding your breath and doing that, you're not going to get nearly as much bang for your buck as if you're breathing out through your mouth, which you love breathing. So it's
yeah.
breathing out through your mouth while you go through opening and rotation and then breathing in through your nose. So you'll just get a lot more bang for your buck as you go through that with breathing. And I always tell people find an object and each time try and breathe out and find that object even farther. So just try and find something a little bit farther in the room.
Yeah.
Whether you're laying on your side doing it, you could also do one that I think we did this one last time where you're in half kneeling against a wall. It's just a standing book opener is what I call, or I'm sorry, a half kneeling book opener, or just half kneeling thoracic rotation is also what it's called. So you have one arm on the wall, your left knee would be up, left arm up, and then you're rotating as well. And then same principle, you're trying to breathe out through your mouth. You can bring your head with you. You could bring your head still if you have some cervical restriction.
Yeah, and even your eyes, right? Like, doesn't your eyes and range of motion have a lot like of
Yeah, your
in
eyes
common?
are correlated. So eye movement is heavily correlated actually with your upper cervical spine. So yeah, eye movement's huge as far as improving cervical mobility, which is also going to help with thoracic mobility because your whole spine is related.
They're all connected.
It's all connected. So yeah, thoracic mobility is key. As far as other exercises go, I mean, a classic is the cat camel. I tend to not give that one as much. I like cat camel, but what I've found is that you'll get a lot more bang for your buck if you lack thoracic extension, which a lot of people do. We lack thoracic extension and rotation, but I've found myself assessing more of the rotational aspect because it is much easier to improve rotation than extension. And
Yeah.
especially, I work with older adults primarily. I'm not changing a 65-year-old man's kyphotic spine. It's just not going to happen.
Yeah, it's gonna take months and months of adaptation and long hours of work, and you just like, let's work with what we got, and we're gonna,
Yeah.
improve on that.
Yeah. And improve the rotational aspect, improve the side bend aspect as well. And you should start to notice that your extension should also improve as well. So, and that's kind of going into side bend as well. That's something that I'll look at, especially with a golfer, is just that right and left lateral movement. Side bend is key when it comes to golf. So if we're, sorry, I'm just kind of
I
jumping
love
around
it.
right now,
Yeah.
but if we're going back and talking about golf and optimizing a golf swing, thoracic rotation is key, but also we forget about the side bend aspect of things. So if we're setting up to a golf ball, we're a right-handed golfer, and we're rotating back onto our backstroke. So we need right thoracic rotation, right lumbar rotation as well. And then we are also going into left thoracic and lumbar side bend. So those couple against each other. So you're going into
Mhm.
right rotation, left side bend, and then when we go into the downstroke, we're going into left rotation and right side bend.
Opposite. Yeah.
So it's really, especially if you're someone that struggles like myself with shallowing out the club, if you can't get into right side bend, that could be something. I mean, you could work with a golf coach all day and they're trying to get you to do these stupid drills of shallowing out, drop your hands, drop your hips, drop your, yeah, I've seen all these crazy things, but if your body physically can't get into right side bend, then you're not ever going to shallow out the club. So that's something that's really huge at looking at, is in not just thoracic side bend, because we're just talking about thoracic spine, but also lumbar side bend can be quite limited for a lot of
It
people.
sounds like a lot of golfers should come get assessed before they go to their golf coaches because, like, yeah, again, if we don't have those ranges or we don't have those things, then a golf coach would have a hard time making those adjustments on you, and then it would, give them a little bit better picture of you when they know your imbalances, and they
Hmm.
can, build a program off of that, and then you can bring that to them. But
Yeah.
yeah, a PT assessment pre-golf would be amazing.
I mean, I'm obviously biased, but I believe that every golfer, if they're gonna take their swing seriously and they want to progress and get to whatever the next level is for them, if they want to go from a 10 handicap to a 5, if they want to go from a 30 to a 20, everyone should be familiar and get assessed through the TPI assessment. So the TPI is the Titleist Performance Institute. My coworker Will Whitlock, I'll give him a shout out.
Yeah, maybe we'll get him on here one of these days.
He's fully trained through the all 3 levels of the TPI Institute. So, what the TPI screen is that you're taking the golf swing itself, and you're also taking any biomechanical movement. So, rotation, hip mobility. I'm sorry, thoracic rotation, hip mobility, internal rotation, external rotation, ankle dorsiflexion. I mean, shoot, even looking at, okay, when you rotate back, what does your knee do? Is your knee fully locking out and extending? Is your knee not moving at all? What are you doing with your body that could be a deficit versus just telling someone, oh, you're not bringing your hands back? Well, is that because their body physically can't move in that
It's very
direction
tight
because
when
they
it goes
don't
that way.
have
Yeah.
right hip internal rotation, or is that because they don't understand the movement of the golf swing? What Will does that's so awesome, and I think it would change every golfer's handicap, is he doesn't just look at their golf swing as a golf swing. He's looking at their entire body as how it functions and if there's any type of range of motion restriction. So he has a cool little app that he uses where he can document everything. So, I think they show like valued norms of like, this is what you should be at. And at the end of the day, there's not necessarily everyone's a little bit different and there's not a norm for stuff. But, if you don't have good wrist mobility up and down, like if you get stuck in radial deviation, if your wrist can't move that way, but your left one moves, okay, well, that could be an issue because if you get to the top of your swing and your wrist can't radially deviate, well, maybe we need to work on your wrist rather than telling you that you're not getting to the top and getting into that position. So maybe it's more of a biomechanical deficit rather than understanding what that position feels like. And that's why I think it's so powerful to go through the TPI swing. And every single professional on tour has worked with TPI professionals.
Yeah.
I don't know if I should quote that,
yeah.
but I mean,
But it
I
makes
see
sense,
so
right?
many
Like,
of these
yeah.
tour guys that are working with TPI, and it's becoming more and more popular in the golf community.
Well, golfers are athletes nowadays. They're taking after the Bryson approach where they lift, now they
Hmm.
do, nutrition plans, now they got trainers, physical therapists, the whole gambit, right?
Hmm.
It's too much it's gotten too big of a sport where that like there's not as many John Daly's out there that just, rip cigs
Yeah.
and drink beers and, play good golf,
Yeah,
but
and John Daly's body was somehow optimally moved. I mean, the amount of lag that that guy could get was crazy. But most golfers can't get into that position. Like myself, I have terrible right thoracic rotation. That's something I was born with because of how my spine moves. And so that's something that I had to adjust with my golf swing because I was getting too high at the top. And then I was just letting my hands just get away from me because my spine physically doesn't move any farther. So John Rahm, for example, he's one of the biggest examples that TPI uses. He was born with a club foot, so his right foot doesn't have good dorsiflexion. He was born like that, and so I think he's one of the first pros that kind of became well known in the TPI community. And he, he went to school here and everything, so I'm more familiar with it. But so John Rahm, his swing is unique. A lot of people that know golf, they know that John Rahm has a wickedly short backswing, but he has a crazy amount of lag on the downswing. A
yeah.
big reason why is because his right ankle physically cannot move. And so he had to make adjustments with his swing. And if you like just look up on YouTube like John Rahm TPI assessment, it's really, really interesting. Just hearing the story about how John Rahm completely adjusted his swing, I think in college, to make it a lot shorter the way that it is so that he can optimize how his body moves and actually use ground reaction forces from his feet up, which is what a lot of golfers don't realize is that from your feet up is how you generate power. It's not from the top down.
Definitely not.
And so I think that was a big issue that he had. And once he started working with the TPI professionals, it changed his golf swing. And I feel like I'm just advertising for TPI right now.
Fascinating. And yeah.
I've
And
never
John
taken a
Rahm,
class,
but
so
like,
I'm not getting paid by them. But I've just seen how, my wife works with Will as well, and I've just seen how effective that type of stuff is. And I've had a lot of my patients work with Will because he's very, very talented at it, and it's very fascinating to see all of the different aspects of the golf swing and how if you just work on improving, let's just say hip internal rotation, which is what you have to access on your backswing, and right thoracic rotation. If you work on that more than consistently working with a golf coach who is just trying their best to get you to actually rotate, you'll make a much bigger change with your golf swing.
get your body fixed, then get your swing fixed.
Hmm.
And then since you've mentioned the hips, and then we already did the thoracic mobility, let's move down to the hips. So like,
Yeah.
what can we do for people in their hips? I know this is a major pain point for a lot of people. Either they have tight hip flexors or they have low back problems because their hips
Yeah.
aren't rotating properly, or so
Yeah. So the low back, I mean, a lot of people just say, "Oh, your low back hurts because your core's weak," and that's partially true. A lot of people have core
a lot of
weakness.
people have core weakness.
But for a lot of people with low back pain, it is primarily attributed to thoracic restriction, which we've already talked about, or hip mobility restriction. So hip internal rotation or external rotation restriction, primarily for the golfer. I mean, for the average Joe, hip flexion restriction, it can be a huge issue for people as well.
Definitely.
I punted in college and I had terrible hip flexion, and I ended up having to get surgery because of that. And I had a bony impingement. And I didn't even know that. I never had anyone assess that on me, and I just thought that my hamstrings were tight, and it started to hurt my back and inside my hip. And little did I know that I had hip impingement. And a lot of people are told, and I was told this too, you have a weak core and you need to stretch your hip flexors out. Well, that wasn't necessarily true. I should have been doing more mobilizations to my hip to at least prolong. I mean, my hips were bad regardless. I don't think there would have been
I mean, over like with that kind of activity, like kick
just
is
overuse.
still a
Yeah.
big overuse problem.
Right.
It's just like throwing a baseball, but with your leg.
Yeah, that's how I was made. But anyway, I don't want to go down that rabbit hole. But hip internal rotation is one of the biggest deficits that we'll see with people that tend to have low back pain. The reason for that is that if we are bending over and grabbing something and we are rotating over our hip, if we can't internally rotate, so if we can't twist over that hip, then we're gonna get overuse through our lower back. So the lower back, like I was saying earlier, is more of an overused area rather than the source of the issue. So it's usually something above or below that area that's gonna create the dysfunction. It's not the lower back is the source. We need to just do core exercise. Yes, I give
Yeah.
people core exercises. I do core often because it's very, very important, especially if we're talking about golf. But if you're not addressing poor hip mobility to improve your lower back, then you're never going to get anywhere. And at the end of the day, all these muscles are attached to your
Everything attaches
lower
to the
back.
back. Yeah.
It's all related. So hip internal rotation, a nice easy assessment. We did a little video of this, I believe, is just laying on your back and just rotating. So you're going to have, here, I'll just bring your leg up here and then going out. So that's internal, that's external rotation, and then hip flexion. So norm values on that, you want to be able to at least have about 30, 35 degrees of internal rotation. If you're just getting that kind of hard stop, that can be a huge contribution to low back pain. So if we're talking just exercises to help with internal rotation, one of the best that me and you went through actually is just doing a banded hip mobilization, which is impossible to explain over here.
Yeah, we'll make a video for that
But
one. Yeah.
I think we have an old video of that.
Exactly.
That's a big one that I give people is just trying to open up that hip capsule to access more internal rotation. I also would just spend a lot of time in standing and just pivoting over that hip. So if you have your right hip still and then you're pivoting your left hip over your right
Oh,
hip,
yeah.
that's a great internal rotation exercise. So when your foot's on the ground and you're rotating to the right, then you're doing internal rotation of your right hip and then vice versa. And so, with the golf swing, like I mentioned earlier, if you're on your backstroke and your right foot is fixated to the ground, that is internal rotation of your right hip, external rotation of your left hip. And then on the downswing, left hip internal rotation and right hip is externally rotating through.
Perfect. And then now we'll move down even further. We have knees and ankles.
Mm-hmm.
So, what can we do for, well, knees are hard again. Like you said, they're usually not knee problems, right? They're ankle problems or hip problems. So I guess we're going to the ankle, or are we going to go work on anything in the knee?
I mean, it depends.
Yeah.
So it's funny. I actually saw this video the other day. It was like someone interviewing like 7 or 8 PTs, and they said someone has patellar tendonitis. What's the number one thing that you think what's the number one deficit that's causing that? And they all had a different answer.
Yeah.
So, and that's because it really depends, and they probably were just thinking of the most recent patient that had that. So,
Yeah.
as far as knee pain goes, impossible to say like this is the number one exercise you should do for knee pain because there's so many different pathologies you can have for knee pain, and that's why it's so important again to be assessed by a physical therapist because you see all these different exercises and tips and stuff.
Yeah, go on
online.
Instagram. There's 100 of them.
And I mean, I will say isometrics for knee pain, one of the best exercises you can do. If you have anterior knee pain, so patellar tendonitis, let's just say that as an example real quick. So right under your kneecap, if you have pain there from jumping, squatting, whatever it is, one of the best ways to fix that is doing something like wall sits.
Yeah.
So doing anything time under tension load, so holding a wall sit as long as you can, doing an isometric leg press at heavy weight. So always doing single leg as well. So doing an isometric leg press at about 70 to 90 degrees of knee flexion. So loading it up, holding as much as your leg feels like it can tolerate for, I call it 20, 30 seconds. Some people I'll even give them longer. And then also just using the knee extension machine, about 70 degrees of knee extension, knee flexion, and just holding that for 15, 20, 30 seconds. So if I'm just going to give some generic exercises to get someone out of knee pain, isometrics all day.
Nice.
But if we're talking about the root cause of it, I mean, some people get patellar tendonitis from just overuse from jumping, like volleyball players.
Or just terrible gait.
Issues. Yeah.
Yeah.
Like, or overuse can be something that's really tough to deal with. Like when you have these volleyball players that are jumping 1,000 times at practice, I mean, what are you gonna do?
Yeah,
that's a tough one. You just gotta manage it, and
right?
that's why isometrics can be really helpful for that population. But if we're talking generally, someone is having pain with squatting while they're lifting, it is most likely, and that's probably one of the most common things that I see is squatting pain or going down a step. That's probably the two big ones that I have patients for with knee pain. It is generally going to be an ankle dorsiflexion restriction or a glute strength limitation. So your glute max has the most amount of muscle fibers in our body. So it's not the strongest muscle in our body.
But
Our
it's the
jaw is,
biggest.
but it's the bulkiest. Yeah.
Bulkiest.
It has the most mass
Yeah.
out of any muscle. So it's the driver, right? It's with walking when we're trying to push through. Our glute max is doing
Hip
that.
extension. Yeah.
Yep, our hip extensor. And then also our glute med is a very, very important muscle as well. So if we're talking running, we're on our foot, we're in single leg stance the entire time that we're running. What muscle is keeping us upright that whole time? Primarily is our glute med, is keeping us stable. If we don't have good glute med strength, then we're going to overuse through the knee. Really common injury that we see is knee pain from running due to glute med, so hip abduction weakness. So having your hip abductors assessed, your hip extensors assessed is key if you're having knee pain, but also ankle dorsiflexion. So if I'm thinking of squatting, and we're in a small room right now, so I'm not going to show a squat, but if we have to sit back and we can't get our shin over our toes, then what's going to happen? Well, our heel's going to come up, and then we're going to overuse through our anterior knee, so the front of our knee. So I actually have a patient yesterday that she was in and this is a really common thing that I see. She was in a boot, 7 years ago, and she was in the boot for 3 months, healing from a fracture. And then, of course, she didn't go to physical therapy or do anything afterwards because doctors don't recommend that for no reason. They just look at the bone healing and then tell someone they're fine, and then they usually end up in PT a few years later because it creates
a new injury,
dorsiflexion restriction. So the reason why ankle dorsiflexion gets restricted when you're in a boot is everything just stiffens up. So that dorsiflexion is your toe towards your shin motion. It's one of the most important motions in our entire body with sports, with walking, with any human that I treat from a young age to 90 years old. If they don't have good ankle dorsiflexion, it's going to create issues up the chain because our foot hits the ground and then everything is a reaction from that. So this lady in particular, she had left knee pain, but her right ankle was in a boot for 3 months, and then it was incredibly restricted. I assessed her closed chain dorsiflexion, which is just in standing, having her go knee over toes. She had 17 degrees on her right, 35 on her left.
Oof.
Huge restriction.
Yeah.
And just talking norm values, 17 is not good.
Yeah.
35 to 40 is what we consider normal. So she was just overusing the heck out of her left side because her right side didn't move. And I had her do squats and her heel would come up every single time. A nice, easy assessment of your ankle dorsiflexion would just be to stand at a wall. And you want to stand about 4 to 5 inches from the wall. Yeah, you want to try it?
Let's try it.
It's, a fist width. Come back a little bit. And a little bit more. There. And this wall has bumps on it, so it's not the most accurate. And then bring your left leg back. So all you're going to do is just go knee over toes as far as you can without your heel coming up. And I would typically do this with shoes off, but it's fine. You have minimalist shoes. So looks pretty good. I would measure the angle, so you get here, and I would measure the angle from here to your lateral malleoli, so your ankle bone on the outside, and then parallel with the floor. So we're trying to see at least 35 degrees side to side. Again, just a general rule of thumb for people at home is stand about 4 to 5 inches from the wall, bring your knee to the wall. If you can't get to the wall without your heel coming up, you probably have some form of an ankle restriction. A lot of people have ankle restrictions, but what I see the most is people like former soccer players, basketball players that had a ton of ankle rolls. And
yeah, no, I actually ran into one the other day, and her ankles are stiff as a rock, like they don't bend.
Right, and it's usually it's something. I mean, some people are just born with tight ankles. Like high school boys, they all have tight ankles for not all of them, but 50% of high school boys just have tight ankles, and that's a big thing that I'll educate high school athletes on, is just improve your ankle mobility. That's something that we did a lot in high school, and I didn't understand why. The why is to optimize your function from the ground up.
Yeah.
But yeah, a lot of people with just chronic ankle sprains when they were in high school or college, or like hikers that roll their ankles a lot. What that does, each time you sprain your ankle, that joint's just going to lock up a little bit unless you get it rehabbed.
Yeah, unless you do the work to get that full range adaptation
to restore
back,
your
right?
ankle dorsiflexion. Yep. And then another thing that will, if you're having chronic ankle sprains and you're lacking dorsiflexion, you're likely going to get calf weakness. And so that's just two generic things that we see all the time is dorsiflexion weakness and then calf weakness, which can create issues up the chain into the knee.
And so for my people in the gym, I like to have them on like a tibialis bar, doing some like tib raises,
Mm-hmm.
and then doing some, like calf raises with some loading the calves up and getting that, and sometimes just sitting in the deep stretch just to get that mobilization through like the whole range, right? But like, what would you do to increase someone's ankle mobility or improve on that?
So, I would use a little mobilization band. So same thing as the hip. So, an inch, probably an inch in width. Have them put their foot up on about an 8 to 12-inch step. The reason for that is that you want to have that band down a little bit. So you would have your foot up on the step, band at your ankle joint, so as low as possible. Now you don't want it over the shin. You want it at the ankle crease. So like I have short socks, so right at my sock crease, as low as
Okay.
possible. And then they're just doing a knee over toes mobilization. I also like to have people work not just forward and back, but working three ways. So I'll have them work over their big toe, over
Yeah.
their third toe, over their fifth toe. Our ankle is a mortise joint. So that means that it moves in various directions. It doesn't just move back and forth.
It's Mortise, but it's not a ball and socket. It does something
It's a
completely.
mortise
Yeah,
joint.
what's Mortise? Yeah, interesting.
A mortise, it's the only joint in the body that's a mortise joint. So,
Oh, okay.
like our thumb is a saddle joint. If you like Google what the thumb joint, the CMC joint,
Yeah.
it's formed a little bit different. So it's not a hinge joint. It's not a ball and socket joint. It's a saddle joint. The same thing with the mortise joint. It's unique in the fact that it can actually move a little bit in, out, forward, and it's not just a hinge joint
Oh,
forward and
okay.
back. I just thought I would throw out a little
Super
fancy word.
fascinating. I didn't know what that is.
It's
so-
interesting because our foot can go through inversion and eversion. And it's funny. Our very first podcast, I think we only talked about the foot and ankle, right?
Yeah.
And I could easily get down a rabbit hole with the foot and ankle, but if we're talking just generic, a great exercise to improve ankle dorsiflexion, which is the number one deficit in the foot and ankle. Now, there's a lot of different things that we could go down, but working on that with a band around the ankle, driving forward and back, having that band go down at about a 30-degree angle, which is why you want your foot up on an 8 to 12-inch box, because that's how our talus slides posteriorly and inferiorly at about a 30-degree angle. So it moves down and back. It doesn't just move back. So I've seen some people doing ankle mobilizations where it's just coming back. That's not wrong per se, but you're not going to get the most bang for your buck.
Okay.
And it's also not wrong to just work it forward and back, but you're going to get the most bang for your buck working it
In all
three
the
different directions because it's a mortise joint. But
Shout out to the
anyways.
Mortise joint. All right, brother. We're rolling up on the last few minutes here. So, any last things you want to talk about that have been on your mind lately, or anything that we can help optimize the golf swing?
I think something that's really been pressing for me lately is just I have so many people that don't know what we do as physical therapists, and that's why I like to do these things with you. Is
Yeah.
just to educate people on what we do as physical therapists. Most people just think of physical therapy as the people that you go to when you're in a lot of pain and you got in a car accident, you had surgery.
Some
and
doctor told you to go there.
Right. And then, a lot of people just come to physical therapy for 6 visits so they can get their injection and then get out. It's probably one of the most frustrating things that every PT has to hear is being told, oh, I'm just here because my insurance is making me come here so that I can get my injection.
Like, can we have anyone that wants to be here?
And
like,
we have a wealth of knowledge that is very unique in the healthcare field. And I'm gonna make it my life mission, my life mission to educate people on what we do as physical therapists because we have such a unique role in the healthcare system that no other profession has. We call ourselves movement specialists because that's what we do. We spent a lot of time in school learning the musculoskeletal system, learning biomechanics, learning anatomy, but we don't just look at this is broken or this doesn't move well, so we need to improve this. Just like I've talked about this whole podcast, we're not just looking at the knee itself, we're looking at the body as a
system.
whole, and we're trying to optimize how your body as a whole works. Just because you aren't having pain necessarily doesn't mean that it's not a good idea to see a physical therapist. Just like we talked about at the beginning, everyone has some form of a dysfunction.
We can find it real quick.
And if you can curb that dysfunction before it turns into pain, you're going to notice a massive improvement in your quality of life. You're going to notice a massive improvement in your sports with just being able to pick up your grandkids, whatever it is that people are having issues with lifting.
Everybody wants the best longevity drug, but probably staying healthy and, maintaining optimal range of motions and strengths and abilities physically is probably one of the least talked about but most important parts of that.
Yeah, and we only have one body, and a lot of people neglect their body, but at the end of the day, we only have one body, and if you continue to neglect your body, it's going to be harder and harder to get out of pain and to get out of whatever dysfunction you have. So my encouragement to people is, even if you don't really have much dysfunction, if you have a little lingering pain, most people have some type of a lingering pain, schedule an appointment with a physical therapist. Have them do an assessment screen, and I guarantee you'll walk out of there having a different opinion of what physical therapy is. Some people know what we do, right? Some people have been in PT, they understand what we do, but most people that walk into our clinic, they have been to a chiropractor because they had back pain, and the chiropractic industry does a great job of marketing that if you have back pain, you should see a chiropractor.
Get realigned.
In general, I don't know why, as a profession, we haven't educated people that we also treat low back pain. And I don't have an issue with chiropractors, but most of them just crack and pop you and then get you in and out. That's
30 sessions of cracking and popping.
That's the business model of most chiropractors. Not every chiropractor. I love some chiropractors, but most chiropractors, that is their business model, and they're okay with it. And I've had patients that are chiropractors, and that's just what their niche is, and that's fine. But if you have back pain and you're just constantly going to a chiropractor and getting your back popped, try a physical therapist. Try and get a full body assessment, and I guarantee you're actually going to get to the root of your problem versus just constantly fixing the symptom temporarily for a week or whatever it is. Same thing with neck pain, shoulder pain, elbow pain, hand pain, whatever it is, ankle pain, hip pain. We treat everything.
We treat the body.
We treat vestibular dysfunction, dizziness, balance. We treat neurological disorders, MS, traumatic brain injuries, strokes. We treat everything that you can possibly think of. That's just what I'm really passionate about, and I just want to change the public perception of physical therapy because it's near and dear to my heart, and I think that we do a really poor job as a profession of advocating for ourselves, and a lot of PTs are afraid to tell people what we know, and I am just really proud of the field that I work in, and I just hope that we as a profession can continue to change people's perception on what we do.
I think this podcast will be doing just that. I appreciate it, brother.
Yeah.
Thanks for coming on again and spewing your knowledge. I love it, bro. And I can't wait to see how you take this on in the future. But thanks again. And guys, we will catch you guys next week on The Price for Paradise. My name's Woody, and
Aloha.
Aloha.